Is it?
Yeah, obviously.
We are live.
We are live. Okay, we are live. Here we are. Okay, so today's a super exciting show. We did receive some criticism on X, formerly known as Twitter, that we were getting relatively high end. I would say the word relatively there is key and important. And I can assure you, loyal fans, that we in fact did our news show approximately 5 minutes ago. I feel like trash, and this will be a very normal show in terms of preparedness. So anyone who thought that this was going to be different is, I am sorry for you.
And the trash haulers are literally outside getting trash right now. So if you hear any background noise, that's the trash removal, folks.
Mostly the trash talker was Matthew Holt. But that's normal. I feel like that's just what happens. Yeah. So anyway, here we are. Here we are. We have two exciting guests today. We have Aneesh Chopra and Micky Tripathi is going to show up, and we're going to actually have them on together because Aneesh said that's what he wanted, and we are here to serve.
It's fine.
So we're going to do our news show. We're going to do some things, and we'll see what happens. So we have a quote for today, since we do have a former federal official and a current federal official, and this is the quote of the day: "Capricious and arbitrary," which is a phrase I feel like they hear often. It's very exciting. And anyway, so here's the news show. So as promised you all, I am here to report on my own IUD insertion, and it in fact did hurt. So as everybody knows, we've been hearing as women that getting your IUD freaking hurts really bad, and we should all do things for that. So I'm here to report that just like last time, it turns out my cervix is dead and I didn't feel it. So just for all of you who are nervous about getting an IUD, I'm here to tell you, it might not hurt, or it might hurt real bad, which is the story of the week. So I invited all the residents.
I can confirm that. Doesn't bother me. I'm good. I think you should talk a little bit more about your behavior in the office while this was happening. That you were bring in all the residents. We got to train them somehow.
Okay. So as everybody knows, I live in a red state. The reason I got an IUD is because I am a little bit concerned that someone might tell me I can't have birth control in the future. And I figured they're not going to take it out once it's in there. That would be pretty dramatic, right? So I figured I need to do all this, whatever. Anyway. And so I go into the office, and first they're like, "We need to give you a pregnancy test." And I was like, "Listen, I know how babies are made. I am not pregnant right now." And they were like, "No, we need to make sure because we could give you an abortion and then we go to jail." And I was like, I forgot I was in Georgia. So anyway, that all worked out. And then they were like, "Can a resident watch?" And I was like, "Bring them all in." So I had 3 residents in and a bunch of midwives, and we were all chatting it up.
You got to train them. They got to get their training. They got to get their
that's what I was saying. I was like, the more people in Georgia who know how to make you infertile, the better. Right. So anyway, but I am here to report that I also kind of think because I'm working on the conspiracy theories, Lisa, because you got to do those things when you live down here. Yeah. And I am kind of concerned the whole IUDs hurt really bad thing. I mean, I know they really do hurt a lot of women. I know that is true.
Totally.
So this is my current conspiracy theory is that they're telling us all in the news that they hurt super bad so that no one gets them and we all have more babies. That's what I'm thinking. So that could be completely wrong, but there you go, loyal fans. I promised I would tell you how it went. That's how it went.
Good job.
Mammograms. Lisa, this is your favorite topic. Maybe.
Yeah, I mean, this is basically, unfortunately, the best we can get is that, they pass sort of some new guidance that says you should at least counsel patients on what it means to have dense breasts and why that might mean that your mammogram results will be confusing and a little bit scary. They come up short. At the end of this article that our friend of the show, Susan Clark, provided to us, it says, hey, still got a lot to do in terms of actually making there be screening that is paid for, that is included in your basic health insurance. If you do have dense breasts, which is a lot of women. So it's important. And I'll shout out to the women's health stuff. I just want a quick shout out. Last night I was at the inaugural Women's Health PAC event in San Francisco, which just launched. It is a bipartisan PAC. They're going to be funding at least 10 members of Congress, bipartisan, Republicans and Democrats, to specifically support women's health issues. So shout out to them, Liz Powell and the whole crew there. They're doing amazing work and super excited to support them.
I should have put that in the news show, but thank you for bringing that up. Okay, so also Susan Clark, friend of the show, she did ask us to put this in, and Lisa, I think you did as well. I wanted to read her comments. We got permission to read them on here. So
Please.
she's excited about this update, right? That it's going to you're going to get some more information. She quotes in here this, one of the quotes from the stat piece is, while regular mammograms are required to be covered with no out-of-pocket costs by all health plans, women who need follow-up screenings may face out-of-pocket costs. And then whatever. So she said, this is Susan Clark. Everybody knows her. This is like her actual words. That part really honks me off.
True. I agree, Susan.
I just had this done in August, so the recommendations on my report suggested another ultrasound next year with my mammogram. The mammogram cost me nothing, but the ultrasound cost me $2,000 to $3,000. So yeah, also Susan's exact words.
Insane.
I will likely push this far out. Yeah, totally wild.
Yeah.
So like progress, but like, not so much
great.
progress at the same time.
Great.
So yeah. Oh yeah, this is like kind of exciting because didn't we see like a year ago, Amy Abernethy was like, I'm gonna go do something in health data. So they launched this week. Lisa, what do you think about that?
They launched a kind of an interesting structure. They have kind of a nonprofit institute level approach, and then they also have a venture arm. So more to come to see how this goes. These, two folks were both at Flatiron for quite some time, medical doctors, data experts, and then Amy Abernethy at Verily. And, interested to see, this is obviously a very hot area. We've got a lot of data companies trying to do cool stuff in clinical trials and connect different aspects of data for clinical trials. TBD. I do like the innovative structure though, and what they're trying to do there to build more evidence and use data for clinical trial stuff.
Oh, I thought I thought you were talking about their weird operating or their weird business structure.
Yeah, the business structure. I think they specifically have a nonprofit institute so they can try and generate more evidence and show more use cases about how you can actually use data to improve and optimize clinical trials, as far as I understand.
So they've
Amy
got
can come on the show and tell us about it.
Oh, well, their PR people said that when they replied.
Yeah,
but we didn't actually go through our email until 20 minutes ago. So maybe next time. But like what I think is interesting about this, whatever, I think it's great, cool. I hope they succeed. But I was reading through the business structure, right? So they've got Highlander Health, and then they've got the foundation, and then they've got a venture, an investment arm. And I was this is what I was thinking. Lisa, I feel like I'm pretty smart sometimes. I feel like I'm good at making money, but I feel like all I know how to do is get money in and spend money, right? And I spend the money I have. I was man, these people and they're I'm doing it wrong. There's got to be some weird reason this all works out, these shell gamey things, and it is impressive. So that's what I read in this article.
About taxes. You need to learn about taxes, Kat. We gotta get you some R&D credit taxes.
I need to learn how to leverage debt. That is recently what I've been told, and I was I don't know about that. But anyway, so good for all these smart people who know how to do shell games with money and things like that. That's great. Lisa, what do we think about Medicare Advantage today?
We're fine. We're fine. Everyone calm down. We love and hate it equally depending on the day. But apparently the backlash that we may have been part of fomenting is backlashing.
Oh, well, we aren't real media, but sometimes things are exciting for us. So yeah, I would like to believe that we in fact had something to do with this, but I don't think that's true.
Yeah, sure. Whatever.
Anyway, okay. Oh, so this is exciting because now we're talking about people making money, and so we're going to talk about the Catholics. I am a post-Catholic individual, so I feel like I can talk about this a little bit. But I feel like this is not news anymore, right? Haven't we been talking about Catholic health systems for 100 years and how much money they make and how they're not actually very nice? Why is this still?
It's not news, but the problem is it keeps happening. And here's my thing: I'm okay with for-profit healthcare systems. They exist in but these folks aren't, and they're hiding behind a nonprofit mission, and they are leaning on the religious side of it for various purposes, but not other purposes, right? You can say, we don't provide these kinds of services for religious reasons, but then you say, well, we do deny care to poor people because of money reasons. I'm a person who's very allergic to hypocrisy, extremely allergic to hypocrisy. It makes me feel really physically uncomfortable. And my thing is you shouldn't be running $1 billion surplus and denying people care, fundamentally. And medical debt, as everyone knows, not a fan of it. Wrote a book chapter in Artists Remaking Medicine with Emily Peters and friends right here. Shout out, and really really, really don't like it. So don't think that's very religious or helpful, and it just keeps happening. That's the problem.
Lisa, without margin, there is no mission. All right, moving on to another rich person who doesn't believe in poor people. You have to talk about this one because I only read the opening paragraph, and it was like this guy.
Listen. This is not very health tech
guy.
This is not very health tech, but I don't really care because it's just, again, like y'all, the greed aspect is pretty icky in healthcare right now. This is about Stewart Hospital. It's a bigger story we can get into right now. This guy just like didn't show up for his like testimony in front of the Senate because they've done some like terrible criminal bad things while he like flies away on this private jet. And that sucks. Just don't do that, please. Come on. There's other stuff to do. Please.
Yeah, there is other stuff to do. That is correct. Yeah. All right. So we like medical doctor Neil Shah. We think he's a cool guy. If you haven't read his preprint, this is like a Substack. Is it Substack or Medium? I don't remember because I cut that part off when I screenshot it. But some people have gotten a little moody about Neil's stuff because I think that they believe
It's me.
Oh, was it you? I thought it was someone else. I think some people think that he's like an advocate for women's health, and I think like maybe that's true, but he's also an advocate for his company, which is all about fertility. And so sometimes Neil talks about men, which are required to make, sperm are required to make babies, and I think like some people get mad about that, but
for now. Just to be clear.
Anyway, we in general really like what Neil has to say in this stuff. And today, I think it was today, or it was on the LinkedIn today, that he had written something about Lisa, one of your former employers, Medicaid models, and they don't have many Medicaid models. So
yeah, the transforming maternal healthcare model, which is like just closing for applications right now. It's a really big deal. It's one of the new breed of CMMI models that is really focusing on deep partnerships within the states, with Medicaid, with state-based organizations, and really taking time to build capacity, including capacity around data infrastructure in states for the transforming maternal health model, as well as there's a innovations in behavioral health model that's very similar in structure that really works on building that state capacity, which is super cool. I agree with Neil 100% here. This is a really exciting experiment that's starting, and I think it will be really interesting to see how this shapes up.
Yeah, I agree. Also, shout out to Maven Clinic. I think they said that they now serve members, Medicaid members in 6 markets. So that is exciting. Nice. I hope that continues. So super rad. Okay, so now we're going to bring on our guests. So we're going to start out by showing this glamour shot of Aneesh and congratulating him on being appointed to the National AI Advisory Committee. We're going to bring him up here along with Micky. They're going to come on together. Well, Micky might.
Has to turn
appear to be. I don't know where he is.
There he is.
We're going to put. There we go. Okay, so Micky, I don't know if Aneesh told you he wanted you all to be on together. So this is like a little bit of a different format for us. But Aneesh, I have one big question for you with that announcement. Is your blood relative not in charge of the Department of Commerce?
You're muted, Aneesh, tragically. I'm sure you're saying amazing things about your blood relative.
The answer is yes.
Okay.
Your cat's referencing my cousin, Rohit Chopra, who runs the Consumer Financial Protection Bureau. It's an independent affiliate Treasury Department.
I got them wrong.
I knew that.
Should have done my research.
Well, as we can tease on Micky, he's also advancing his version of TEFCA. So it's called an open banking rule, and they're in the middle of rulemaking over on CFPB. So we've got a healthcare TEFCA, we've got a open banking TEFCA. So
oh my God, so many.
Nice.
Actually, very excited.
But actually, shout out to your cousin Rohit.
Yeah.
They just came out with an amazing like multi-year investigative finding, and they're actually banning the former Sally Mae from sort of administering the student loan program, which is like, that's pretty serious. Like that's a pretty serious move. So shout out to your family, Aneesh.
In all seriousness, homie don't play. He is and very effective at what he does. So let's just
nice.
He keeps the industry on its toes. I will make that very clear.
Oh, that's very exciting. Okay, so you're now on this National AI Advisory thing. Micky had to resign from the chai thing. What is the deal? Like, are these overlapping? Like, what happened? Like I read the lines, Micky. I know that's because like conflict of interest, which I appreciate, but what's the story, you guys? Like, what's all the coalitions and the councils, and the advisory committees?
You
guys like to do this together, so yeah, I don't know. You guys are just gonna have to go with it. We don't have any plan.
Yeah, sure. Yeah, we participate in a lot of these things. I think, and as we were as the department is starting to get more and more involved, across the board, and I became the chief AI officer, you start to get concerned about, wait a minute, there's a collision course that could happen here with different kinds of regulatory things or whatever that are now under the department that maybe I'm not even aware of, right? It comes out from one of our operating divisions, and all of a sudden this issue comes up. Wait a minute, this collaboration you're in has been involved in discussing this with this, and or with you, and I had no idea that this other thing was coming out. So it just felt like, you know what? Now that I'm chief AI officer, the scope of responsibility is bigger. Makes more sense to just sort of keep the participation at the same level with all these different collaborations.
Yeah, I mean, I agree. Why be a coalition member when you're in charge?
So look,
that's what I said, Kat. Yep.
Yeah. Is that what did you send a letter?
When you're dealing with emerging technologies, to be effective in a policy role, it is important to have your hand in the pulse of what's happening on the ground so you can make the best possible judgments. And so there's a lot of positives from collaboration and engagement. Micky highlighted the obvious point, which is at some point, formal decision-making will take place, and therefore you want to be clear. I'm in the opposite role, which is the Congress in the National AI Act created a National AI Advisory Council, actually signed by President Trump. And so it's, bipartisan. Technically, I serve a 3-year term. So regardless, there'll be a change. There are 2 candidates, not the incumbent. And so we will continue our role. And so Congress basically said, we want you to do a certain set of things, advise on the future direction of the country's, investments and strategies as it relates to competitiveness. And obviously we have a kind of a commerce role in that they operationalize the work we do. And they've got the AI safety program. And the White House is very active. In fact, we have a dotted line in through my old stomping grounds, the OSTP, the Office of Science and Technology Policy. So I chose to do this. I think it's my first formal role in the Biden administration because I felt that this was, in a way, formal and structured independently of anything that's ad hoc and informal, which I think we do a lot of in healthcare.
Mm-hmm.
But
it's a real FACA. It is a FACA.
Yeah, the whole thing. It's a whole formal.
There's lots of rules around FACAs.
Oh yes. And so, but the great news is I get to work with Micky in a more formal way because the agencies get involved in the National AI Advisory Council. We actually engage in testimony and collaborate and report writing. So it's a lot of fun.
Because I don't hear enough from Aneesh.
Yeah, I was gonna say, has this changed anything? Like, are you like the volume of text messages? Right, you're like,
yeah,
respond to this guy.
I hear, I've never received one of Aneesh's 400-page emails, but I hear a lot about them. I actually feel like our interactions are relatively short. It's like you're coming to my party and you're like, yep. There's not a lot of discussion going on there, but I do hear your emails are epic and should be compiled into a book.
So I have to explain to health tech entrepreneurs all the time, hey, you can talk to the federal government. You can call them up. You can write them an email. You could write them a letter. In theory, you can you can talk to they want to talk to you. You shouldn't say totally outlandish things to them, and you probably should be respectful and follow the channels. But you can talk to them. Aneesh is the living, breathing embodiment of you can talk to your government and tell them what's going on.
You don't need to talk to me to talk to the government. You can talk directly.
That's right. You can talk right to the government.
Welcoming.
There we go.
And the guys.
Micky.Tripathi at hhs.gov. Micky.Tripathi at hhs.gov. And I stay on top of my inbox, believe it or not.
Can confirm.
All right. Yeah. There we go. All right. Okay. So we're going to talk about some data exchange here, y'all. And then maybe we'll talk more about AI. And then, Micky, we have a rebrand of TEFCA to show you in a little bit. It's only
We're
7 months.
hoping to get it confirmed live.
We're hoping. We just want to get
yeah.
your feedback. We just want, we're former PR girls. Like we know how to do a branding presentation, so we got some things for you. But okay, so Micky,
now the Q-hints are real.
So we, you can't do the same. You can't do the same trick twice. So we're moving on from there, and like I don't know.
Whole new paradigm. Whole new genre.
This is entirely different. There are no cats in this rebrand, so there's other things in there. But we're not there yet. So okay, Micky. So if you had become the national coordinator, and there was no congressional requirement that you had to make the TEFCA, what would you have done to make health data exchange more effective? Like if it was not a thing.
If TEFCA was not a thing, and so I was
starting
not required. Never even included.
No, it's 2016. You're walking in your national coordinator. What do you do?
Oh, 2016?
We could walk in 20.
I'm having that as
let me go with
skipping Don Rucker. Are we just skipping
what I got from Kat? I'm coming in in 2021, but TEFCA was not a part of the 21st Century Cures Act.
Didn't happen.
Okay. Yep. I think we would have done something very similar to what we're doing with perhaps sort of a little bit of a different set of requirements and a little different foundation. The reason I say that is that we still had the issue, which we ended up addressing, which is you got FHIR pushing really hard on FHIR APIs, but there's a scalability issue. You need these shared services in some way to be able to scale those FHIR APIs. And the biggest promoters of FHIR, like me and others, were saying that. And so I think we would have said we need network services for FHIR. So does that mean that that we wouldn't have done IHE-based exchange, whatever? I think as we start to think through it, we would think, well, wait a minute, you have to have a bridge to the existing exchange networks, most of the state and local HIEs, the existing nationwide, interoperability networks. So I think we would have gone down the same path. And you need public-private participation. I just don't, it may have taken a little bit longer to crystallize. At least we had a starting place. We did refine it a lot and reset it a lot, as you may have noticed from what we inherited. But it gave us a framework to be able to pick up and run with.
Kat,
do you feel like you were behind? Do you feel like you were behind in terms of bringing in the other agencies and general human services and public health areas? Because it feels like that's been, there's a lot there, and there's a lot of work to get even close to where we are in the clinical domain to human services and public health work. Starting that earlier, I don't know.
Yeah, I think that the version that I came in with and then I adopted, there were a lot of things in it that, from my perspective, would not have made it feasible in the market. And so that was that was a big reset that we had to do on that. And that's why we didn't have a whole lot of federal agency engagement, because I think they were looking at that and thinking, I have no confidence really that this is actually going to go. And I'm just being transparent here with however many people are listening.
It's at least 7. There's nobody listening. It's totally fine. Just between us.
So we took a really good hard look at it, and we literally went back through the common agreement line by line in a pretty painful exercise, because I felt like it really needed to be aligned with market realities. Recognizing that if we had come in, 21st Century Cures Act had said ONC has the authority to require everyone to participate in this, or ONC, here's $1 billion. Go and bribe whoever you need to get in. I'm speaking colloquially, everyone. But here's a set of incentives, right? Then it would have been a very different formula, right? Then you can sort of say, no, TEFCA has some authority to actually, drive different kinds of policy perspectives that we may want as a country, like patient consent above and beyond what HIPAA requires for TPO, for example. But in a world where it's like, well, this is purely voluntary, it's like, well, you're always, we have to figure out how are we going to get this to a point where the private sector is going to say, this is actually valuable for us in a voluntary way to actually invest our own money, because it gets us to where we want to be, and we can't do it without the federal government helping along the way. So that was what we were very keenly, sort of focused on.
Yeah, awesome. Aneesh, what are you going to say?
I was going to flip the inverse of the question, which is,
Whoa, flip the inverse.
I'm confused.
In-
Now I was
I'm not getting back to, I know my, yeah.
like that?
But I'm
It's the
ready.
inverse, so you flip it,
Ready.
So we're back to where we started, yeah.
So you have the authority, but you're not Mickey. What's the probability we land the plane? So as an outside observer and a historical skeptic of the construct behind TEFCA, okay? So pre-2021, if you asked me to gamble, what's the probability of outcome A or B, I would probably have gambled less on where we are today. So the point I want to convey to you, Kat, is on the one hand, it's a little bit of a Rorschach test because, the authority in the law was only but this much, and one could take it as a springboard to like will into existence the level of participation you need to the point where it's almost like now this thing is like happening, right?
Mhm.
Or you could have said, well, it's a this. I don't really have faith that this is going to really happen. So it exists theoretically, but maybe we have to work around it. And so it takes a leader to believe in it. This is a challenge in Washington. Congress gives you authority or asks you to do a thing, but they may not necessarily have given you all the tools you need to make sure that whether it's Mickey or Schmicky or Flicky or whoever is in the seat, that it happens. So there is a little bit of, and the term we used to use was policy entrepreneur. There's a little bit of Mickey as policy entrepreneur that's worth pointing out, because when you have a goal to scale healthcare data sharing and you've got the experience Mickey has and you're given the raw materials, if you've got an entrepreneurial mindset, you can see a path to get stakeholders to want to be a part of it. That's going to be part of the story, touch wood, as we look back to say what went from being a low probability of success to almost like a fait accompli. And you'll find in it, the lawmakers aren't going to say they added any new money or they added any new laws or they had more authority. It's going to be that an entrepreneur in a role can do more than just what the role might narrowly say. And that, I think, is a very important lesson for folks that want to do a tour of duty in Washington. There is an opportunity to do more. And Lisa, you lived it with the AI challenge at CMS. There was no budget, authority, mandate, requirement. You willed
call
it.
people up.
So
call up everyone and ask them for money a lot,
yes,
which is something I've done a lot in my career.
Yeah. So you got to highlight both. What would you do if you didn't have the authority? And then how does a policy entrepreneur take the authority and run with it? These are two critical questions.
Well, I'll tell you, I remember talking to Mickey now a couple of years ago, and I think we were at one of the many conferences we overlap at, Mickey, and it was relatively early on getting back, and I was like, hey, this guy's going everywhere. He's and I think you said to me, you're like, yeah, I just decided it was time to get on the road, and I'll be on the road until the end of this thing and just talking to people. And that's what I think that's what you mean, Aneesh, about being, you literally have to go and sell. People don't like the word sell, but that is what it is. You're selling your policies and your programs. And part of that means you actually have to get out there in front of people, which is also not comfortable for everyone. Kat loves to sell, and she's good at it.
I love selling.
Not everybody.
I love selling, but I also get money when I sell things, and it does not appear that being this policy entrepreneur is the same kind of situation. Like the reward seems much more limited. I don't know.
Minus those $1 billion bribes. Other than that, we're good.
You let me know if that ever happens. So Aneesh, I totally agree. So when this all came out, a lot of my clients were like, first I had run the numbers, right? I'm like, we can't make money off TEFCA. Like we can't do that. No, that's clearly like not entirely the point. Right. But I think a lot of things have changed. And my advice was like, wait and see, like, unless this thing gets mandated, I don't know if you guys want to do this. Right. And the tides have really changed in the past year. So I guess all of those presentations at all of those conferences and coming on fake media shows like the Health Tech Talk Show does appear to be working. So it probably actually was.
We might have gotten the content right too. Yeah.
I mean, there could have been a lot of things. Well, so question. So a lot of us said, like us being like the great free private sector, right? We were like, unless this gets mandated, like, and so we'd like mush around and we'd call people and say, does anyone think it's going to get mandated? Like someone call CMS, right? And it seems like you've gotten around that in a really meaningful way. But like, if you could go back 4 years ago or whatever, 3.5, well, whatever, would you have preferred a mandate?
I'm not sure. My experience with mandates working in a number of different states is that they don't work real well in the places where we've had those mandates. People do it as a check the box, right? They're, in lots of those places, they're kind of like, fine, here, I'll send whatever data you say I need to send, but I'm going to do all my other stuff over here. And that's the experience we have in Massachusetts. It's the experience that, I don't want to start naming names, naming states, and make them feel bad or have them yell at me. But that's been.
I personally hate mandates, so I'm here for that.
Now, I will say that at a national level, one could make an argument that, well, no, if the federal government was kind of behind this and it was a nationwide thing, that might be different because people might feel like, oh, that's scalable and that's here for real, and I can do a whole bunch of other stuff on it. That might have made a different dynamic, but but my instinct is that, I like to always focus on the opportunity side, right? Make this something that people find valuable, and then sell it to them on the value that they're going to get out of it, and you'll just get much better engagement anyway.
Well, we're all living in the world that is the aftermath of meaningful use. And there are lots of implications that have led us to where we are today on interoperability and on healthcare IT and health IT in general that are the result of policy and program and money decisions that were made then. And, best of intentions, I'm sure, but at the same time, there are some really serious negative, effects that have gotten us here, right? I think just, having sort of lived through some of the meaningful use side on the healthcare IT side, and working with practices and physicians on their sort of first take at using an EHR and integrating that into their work. That's when I first personally became aware of the difficulties of adoption of technology in a meaningful way in a clinical setting. And I think because of the path that was taken then, we are still living with sort of kind of light adoption, like not deep redesigned workflows. What are your thoughts about how we actually take some of this? Because we're doing like high level stuff on interoperability, but we still have a gap on the ground that is super pervasive. And then you take that out to human services and public health, and it's an even bigger gap, right? So we still have a gap of implementation. What do we do there? How do we get beyond it?
You want me to go first?
Don't say it's my job, or else
$1 billion bribes.
Yeah, so I got
bribes, I think would work.
Kicking you both off and say it's my job.
I'm a little bit more positive about. I think a lot more positive about the High Tech Act and the incentives and the benefits that provided. Because to your point, Lisa, it's really, really hard to get this kind of adoption of these kinds of technologies from an industry that was very craft guild like. It's different now, right? There's a lot of consolidation happening and stuff, but it was very craft guild, and getting people to move from paper to electronic, that binary step was huge. And we did this in Massachusetts. I mean, I'm really old, right? So in Massachusetts, in 2005 to 2007, we did get a bunch of money from Blue Cross Blue Shield with the Massachusetts Health Collaborative, $50 million to implement EHRs on the ground with 600 providers in Massachusetts, and none of those providers had EHRs, which was the first shock to us. Like, we just chose 3 markets, and then when we went in, it's like, wow, literally 0 EHRs on the ground. And then, harsh discovery was that this is really freaking hard. Like, these people, they're used to paper, and they've spent all this time with paper workflows and trying to get them to move to electronic. And we had all these ambitions about, we're going to, plug them into Health Information Exchange, and we're going to do data analytics and create this data warehouse all at once. And then we realized, whoa, we have to really phase this, because just taking that first step was hard enough. Like, they got to land safely. People always criticize EHRs for, the billing is, so baked in. I mean, our lesson learned with the Mass Health Collaborative was that if we didn't solve revenue cycle first, we lost
Nobody
them,
was going to do it.
Right? They stopped getting paid, and then forget it. I mean, that's just reality that you just have to sort of face up to. It's like, people need to get paid, and if they're not getting paid, and the system doesn't work to allow them to get paid, then no one's going to care about anything else. So the dust had to settle on that, and that takes a long time, right? That's right. I mean, 100. And I would argue, though, that we are now, to use the tortured Gartner analogy, I would argue that the trough of disillusionment, hopefully we have come out of the trough. And now you have value-based care, you have people, who are really thinking deeply about how do I use my EHR for these other things. And yes, it isn't uniform, but if you think about what a larger part of the market than, I think people recognize are actually doing and trying to do with their EHRs, I think it really is more than just the superficial stuff at this point, in part because we're also digital natives in a large part of the sector, not all of it, obviously, but as more and more of us become like digital natives, you just do start to slowly think about, wait a minute, why am I, printing this out and then writing it on a form and then faxing it and then scanning it again? Wait a minute, maybe there was something.
Yeah, but EHRs are not like, TikTok or the Apple operating system. They are old style, software as a service now. At least they're software as a service now.
But residents are now trained on it. It's not like it's just popping it in the middle of their lives and their workflow. True. So I think it's just the way it is. But Aneesh, you were CTO of United States of America. What would you have done if you were the national coordinator and there was no requirement to do TEPCA? Because everybody knows you're like the fire guy.
No,
well, but fire.
Yeah,
fire.
No, let's take this.
Hey, I used to be the fire guy.
Yeah.
Now Aneesh is the fire guy.
So
well, now you're an official, so you don't get to be that anymore. Maybe later.
Right.
Yeah, and I think this is probably a useful little bit of framing in history, because I didn't know the word fire from Schmeier when I got into office. So it'll
Micky, fire.
Yeah. I'm just looking out.
So John Glasser, Godfather, right? We love and worship him, was a part-time advisor during this like insanely intense period of year one of meaningful use. And of course, the imprinted in my head, he says, yeah, we've had an electronic health record for 30 years, right? All that. I can't generate a list of patients who smoke. So we justified meaningful use because it was supposed to be coupled with care delivery reform in the ACA. But for political complicated reasons, it was split to go under the Recovery Act. And so you kind of got paid to adopt technology when we were anticipating a demand signal that did not exist, where you'd want to know that list of patients who smoked because you'd get paid better and more if you actually help people enroll in smoking cessation and prevented that downstream effect on their lung and their body and all the rest. So the second, kind of aha was that the VA showed me a chart in the DC clinics where the blood pressure control, patients that had blood pressure controlled, went from in the 20s hockey stick up to 75 and 80. And you're like, whoa, this was part of the Million Hearts, dream.
Right on.
Do that. And the answer was they made every clinical encounter at the VA take blood pressure in this DC location. And so you come in for a routine, in this case, people had a lot of PTSD consults, visiting with mental health clinics where you don't normally collect blood pressure. I don't recall that being a thing that you do. And they were a little bit annoyed, like, why are you messing with our workflow? By mandating blood pressure capture at every touch point, not just primary care or cardiology, they got a boatload of underdiagnosed patients with blood pressure issues, and they were immediately referred out to get a change in prescription. Meds weren't working or something. Patient wasn't feeling sick. They hadn't reached to the point where they had an acute issue, but they were probably feeling all right, and maybe we're changing their meds or whatever. So we took these very real kind of economic misaligned incentives and said, we will eventually have an economic model that will bring doing this as a core part of healthcare delivery. Now, that demand signal is still just breaking through a decade later. So obviously, if you ask me what's the single biggest thing I'd do for interoperability, it
tie them together.
Band-Aid on the timeline.
Right.
That's dreams, right? We're not there yet. So we had to we say, hey, eat your cabbage. take that extra minute to record these things, because while you may not necessarily have an immediate need, oh, by the way, when it's shared, someone will, and it'll help reduce downstream effects, improve quality. So the pragmatic reality was we needed an economic model that drove interoperability, and then consensus on the how, which is the other funny piece. My last comment, which is going to lead to fire. Micky, you might remember this. There was that in the initial year of meaningful use, the assumption was we were going to mandate whatever the HL7 standard was to capture a patient's medical record summary. And it was colloquially referred to as the RIM version 3, the reference information model 3 of the continuity of care document. Man, it was like a gigabit file in a 2010 era. Like, it was a big document. And I think the standards community may have just sort of like said, yeah, this is a good idea, stick this in. But it was an impractical document to generate and to send around after every encounter. And Chris Ross from the Minute Clinic was like, dude, I generate at Minute Clinic a summary record. We used the CCR, which was this like super skinny record. And we email it after every visit. Do you want it? Click here, integrate with Google Health, Health Vault. And he's like, that works. Like, it was really simple. So we had this like big technical fight. Like, of course, ONC would mandate the HL7 standard, right? We're like, whoa, this could be a burden. So we effectively kicked the can, and we're like, well, either you do the CCD or the CCR. And it was a signal that we didn't have enough kind of technical work on what, because the demand wasn't there. So people weren't really testing it out. So that really did spark a lot of interest in, geez, what should the path be? So we skinnied down the CCD. We funded the R&D project that became the Smart on Fire protocol, in part because there was this like, hey, a demand signal's coming. We got to have the engineering to test and validate and be ready for scale. So I'm answering your question in a long-winded historical way. But Kat, you got to get the economics right? The incentives of the market. And then
Aneesh, I know how to make money. That is like what I do.
Yeah. Well, unfortunately, interoperability today makes money for risk adjustment in HEDIS, which is a Medicare Advantage driving use case, which is why Micky's TEFCA for operations, we have to get into this, because today that's just like a burgeoning new concept. We have to make sure your audience is aware of this, because it's the biggest area of interest, in my opinion. The economics are there for HEDIS and quality measurement. The economics are there for risk adjustment. But for general care management and care coordination, it's a challenge to see if this is an administrative burden or not. So that's why CMS and ONC's alignment was so critical. And obviously Micky's news this year about like formalizing that has been just.
Well, what you say is interesting, because you bring up the issue, that the reason why TEFCA is, evolving or has evolved a bit, and why the other national networks and frameworks have also started to change. And that is because there were significant issues with the free lane of data exchange in the treatment use case in care quality. And I think, operations is really, really important, as are the other like basic use cases that should be there for a national network or a framework like TEFCA. But there are reasons why they hadn't taken off before. I remember I was on the Care Quality Steering Committee for a period of time, and we spent a tremendous amount of time working on the operations use case and got nowhere. And the reason I think, I don't know, I'm not certainly not the expert on it. I've asked Brendan's opinion on this, and know he's watching us, is because these are competitive forces. It's not going to be free, because you're using that data, if you're pulling it appropriately under operations, for a money creating, revenue creating purpose. So for you to be like, I deserve to get this for free, that's not going to work. So how do we ensure the integrity of the network and the framework and make sure people are using the lanes for the right thing? I know that some of the changes have been made recently, Micky, and there, some of those are in reaction to that. It was an attempt. We'll see how it goes, but getting the players to actually agree to formalize and finalize and make those other use cases real, that's the next big step. And by the way, as you know, that's going to take more than 3 months, I think. Just looking at the calendar here.
Micky might stick around. I mean,
Well,
like the rumor is that you're out, but like you might not be out.
What makes you think that 3 months is a magical time?
Just looking at the end of the calendar year and hoping and thinking about the next administration. You know,
a lot of things could happen. Yeah, I mean, a couple of things. One is we very specifically, as a part of the release of the of the policies in early July, with the TEFCA community, talked specifically about we need to do two things. We already had more in TEFCA than existed in most in the nationwide networks. And that turned from being a little bit of a burden to people saying, oh no, that's what we want. We actually want more of that, right? At first it was like, boy, this is what happens when the government gets involved, right? I mean, it wasn't like overwhelming, but it was like every one of those things. And then all of a sudden these issues started arising. And it's like, oh, thank goodness we've got TEFCA to be able to start to build a little bit more. And so certainly we take lessons learned as well, right? And some of this stuff was surprising to all of us. I mean, at least for me, right? It was a little bit surprising to me because you sort of like, wow, this has been going on for so long, and why all of a sudden is it exploding? But anyway, we wanted to make sure that we were recognizing what are those things and how do we build into TEFCA things that will give people trust that we're not going to face those same issues. And a big part of it was to be able to say, we need to narrow what's allowed or what's permitted on a required response, or the privilege of being able to have required response. We have to narrow that, but everyone needs to agree that with narrowing that, we also need to expand the other ones, because that wasn't the only problem, right? One problem was, yes, that was a little bit too loose on that side, I would argue, my personal reflection. It was a little bit too loose and open on that side, but a part of the issue was that people didn't have channels over on this side, right? Healthcare operations and these other use cases. And so they were bending over backwards to try to call things treatment. And so, so that was a part of the, really the, sort of the big collaboration and consensus that we came to was to say, all right, narrow this, open these up. And so that's why with healthcare operations, I mean, I'm really excited that, that we built a model that says, all right, we are going to do this. It's now official. I mean, you can do healthcare operations, and we've agreed to do that in a way that builds trust, because we also recognize that what's prevented that to happen in the private sector alone was the competitive, adversarial relationship that you got, with payers and providers, right? And so being able to just sort of say, look, we have to cut through that. We, with the federal government, maybe can help steward a little bit of a conversation and a trust roadmap here to say, can we all agree that we need to, get over this, for the sake of the industry and for the sake of patients. Everyone's doing it about the patients, right? Everyone
can agree on that. Yeah. So everyone's
so we put in the glide path as well, which is to say, oh wow, Aneesh is gone.
He's gone. We did not cut him out. We did not X him out.
He clearly doesn't. He's like, you're talking about caring for patients. I'm done. Yeah, I don't care about that.
I'm out of here. Where's the
all I care about is bulk fire.
No, I mean,
it's now optional for 18 months, right? And that allows us to build trust. And it also has some well-defined paved pathways or well-defined swim lanes that sort of say you can use healthcare operations for care coordination, for quality reporting, for HEDIS, for population health management. Those are the 4 right now, optional for 18 months, but people agreed that we're going to add additional sub-use cases along the way. And after 18 months, it'll be required response. That feels to me like, that's much more progress than we've ever been able to make.
Yeah. Oh, he's back. He missed the treatment conversation. Well, no, I mean, I totally agree. I think what a lot of us, when we were looking at how the hell we make money off TEFCA in like the early days, and we were like, we can't, right? A lot of it was some of the threat, of course, was that it's going to commoditize data, and data has a high price right now, and blah blah blah. So yeah, I think if we can tackle that problem, it'd be awesome. So also interested in what you both think, because you're both kind of like private sector-y people. I think Micky, before anyone who kind of knew about you before your current role was like, Micky Tripathi's like a private sector guy, right? And I think you both had that vibe. So interested in what you think about this. So there was no money to become a QHIN or anything, right? There was nothing from the feds to really help them out or any incentive. Do you wish that there was?
Yeah, I mean, I guess I'm thinking back then, maybe it would have been a little bit faster and easier to get people to the table, because it's always, it's an incentive to get people to start talking. I mean, at the end of the day, unless you have something that's, going to be an ongoing thing, they're still going to decide based on what value they find, right? So at some point, it's like, we are always, in the private sector, and you probably have this experience as well. It's always easy to raise money. It's 5 years from now. How are you going to continue making money? That's the biggest challenge, right? And so for a lot of these organizations, they might be like, sure, we'll take your $1 million grant or whatever it is. And then 4 years or even 2 years from now, it's like, all right, we're done,
Yeah. Well, it's almost little like HIEs and high tech money, right? They ran out of high tech money, and we saw they just kind of a lot of them went away.
Absolutely. So like in hindsight,
McDavitt spreading misinformation.
Off, right?
I'm just telling the truth.
Actually invested their own money, and and now they've got real skin in the game, and they themselves had determined the value, and that's why they want to stay.
Just to be clear, spreading no misinformation here. Lots of the organizations that exist today have various sources of funding, incling
and a lot of them went out of business.
A lot of companies.
There used to be a lot of HIEs.
Absolutely ridiculous. Look at this in my own home.
There were, but that's okay. I think that's okay. I
agree.
People could be willing to say, and we did this with the Mass Yell Collaborative, and where we at some point said, you know what, our mission is done. And we shouldn't be ashamed of that. We should just say our mission is done. Let's get together with stakeholders, issue a final report, and say, the purpose of our organization isn't to just sustain the organization and have a nice dinner at the Mass Medical Society every 2 months,
or pay for the CEO's private jet, for example. Not that I have a private jet, but
Wow, did I have a private jet? If I did, I'm unaware.
Yeah, it is important to note, one-time dollars to seed, they have two reactions in the market. Those who are like, I'll run this until a point in time when I can ask for a re-up. And the culture of a lot of one-time grants is like, how do I quickly create political mobilization to justify keep going? As you can imagine in my tone, that's not the winning strategy. Right. I'm a big fan of John Halamka, of course, one of Mickey's oldest friends. When John and I rode the M2 shuttle bus together, and he taught me all about how he was building sort of internet-based kind of care coordination tools. When I wrote a little case study on John about the New England Healthcare EDI network. John essentially said, instead of relying on kind of commercial grade, EDI platforms to change healthcares of the world, let's kind of collaborate and use a model that has more of like an incentive to lower the cost model. Maybe it's a co-op, you want to call it. And so because of the culture of Boston, 3 payers, 3 providers came together. I don't know, Mickey, if you remember that chart. Cost per EDI transaction went from up to here down to here. Yeah. So
we took over Nehan. So we ran Nehan for a number of years. And the famous story is that it was actually the John Glasser, we already mentioned, John Halamka, who literally were at a conference in New Orleans, and they drew it out in a napkin. They were like, how about this? We all have to do these HIPAA transactions. How about we do it this way? And that was the seed.
But remember, Mickey, they didn't white label some vendor like morphed thing. Which is, I think, where a lot of the HIEs got into trouble. They just basically became skins on top of existing technology that needed to be subsidized and was not on any kind of cost reduction curve, was on like a vendor contract management kind of curve. Whereas John's and their peers on the payer side, they had every entrepreneurial incentive to nickel squeeze this, twist that. And they did that with an integrator. CSC Healthcare did that work back in the day. So they actually created the technological governance to bring that transaction. And so if TEFCA and the QHINs create more of that, like, in a way, the lack of federal funding almost required them to be, MacGyver style.
Yeah, right. No, and you want to commoditize what you can commoditize, right? And if you can keep pushing that down and commoditize the hell out of it, then people start thinking about, how do I squeeze a half a penny, out of this? Where right now, no one really thinks of it that way. The other thing I'll just add, and I won't elaborate on,
they sell data, just to be clear.
Well,
That's the risk.
yeah, I mean, that's it. Yeah. So that's
God bless
another
America.
conversation we should have. So, but the point I was going to make is, the more if you're actually giving money, or you have other kinds of things, you have a whole regulatory overhead that now gets applied to that. And I would argue that would be, the death of TEFCA. Where we never could have done the quick policy turnaround of the things that we issued in July if we had to go through some regulatory process every single time we wanted to make those changes. I mean, there's no way.
Right.
All right. We've got 4 minutes left. We still need to show you your rebrand, but I want to bring this back to AI, right? Because we need to have good data infrastructure and good data to like make the AI stuff work, right? So, question for you. I don't want to minimize the work that went into TEFCA and information blocking and all that. That is a lot of work, and people are always like, "Why didn't you fix this?" And it's like, I did a really hard thing.
Right. So what have you done for me lately?
So exactly right. So what do you think as we think about AI policy and like how it's either going to kill us or save us? How do you think about the actual quality of the data that's now being transferred? Because Lisa and I talk a lot about like a lot of the data is just trash. So how do you fix that? You have the infrastructure now, or it's getting set up, it's moving. How do you address that so that we don't have like trash AI?
Yeah, I mean, I think it's I think that so there are some types of AI tools that may help with the improvement of the quality of the data, right? It's not going to be a magic solution, but that can help with part of it. But it is certainly true that the quality of your AI product is going to be completely dependent on the quality of your data. I guess the issues that I worry more about from a data perspective are that the data generation process determines kind of the data, right? In terms of what does the data actually mean, and that people are going to misinterpret what that data is. One of the classic examples, electronic health records are used for clinical care, and they've got a billing component to it as well. And people want to use it for research, but you start to think about, well, wait a minute, does it really capture does it really capture data in a way that really reflects what the kind of information you want for research? And I think those are big questions, deeper questions about the structure of a data generation process, and does the data, no matter how much you clean it, structurally support what it is you actually want to infer from the data.
Right.
Remember, Kat, Apple Health did not allow providers to appear in the Health Records app search function unless their local Fire server met conformance testing. So this quality question is absolutely do not pass go and do not collect 200 unless you go through that step. And so there is a little bit of a public-private. Inferno.healthit.gov is essentially an open source conformance testing service. And frankly, I would encourage all stakeholders to test their own capability to make sure what they meant to say is captured in the information that's shared.
We also don't have good outcomes data, right? So like you're learning based on what people are doing, but it's like, except we know 50% or above average in terms of outcomes. We just don't know which 50%. So we'll just keep learning and replicating what people are doing.
And given the time, I'll just sort of I wear another hat. I'm on the National Academy of Medicine's kind of end of year, like what's the next version of the Two Eras Human Report. And I will tell you, I am focusing like a hawk. The dream of the learning health system is that we would be actually organizing the data that's running through these pipes for the purposes of learning what's best practice, what's not. How do we get there? The only platform that's open for learning health system is the CMS research database. That's the only one that's publicly accessible that you can use to learn these things. With the advent of TEFCA networks and the US CDI data set, we absolutely have to have a strategy so we can learn from it, not just the transactional benefits, but the secondary benefits. Because what's the protocol for Ozempic that won't break the bank, that actually gets people where they need to go? When we look at this like emerging technology, every question you could ask, it is the case that it was the Israeli interoperability platforms that taught us
don't remind me, Aneesh. It's one of my most angry things about us not using American data for American healthcare decisions.
Because we didn't have a place to put it or a governance model to organize it. That's what's
all right.
We got
you guys. We got to end with our little. Okay, so we got Aneesh here. Also, I have been told that Aneesh, you have been called by a major media outlet, the Indian George Clooney. I don't know. Well, our audience can be the judge there.
Keep
But so
going.
yeah, okay. So Lisa actually came up with the Freedom Health Data Network, which would be a rebrand from TEFCA. I think, Lisa, why did you come up with this amazing name?
Okay, listen, government loves acronyms and they're terrible, and everyone else thinks they're ridiculous, doesn't understand. TEFCA is so hard to say, and it does not describe what it does. Whereas the Freedom Health Data Network does.
Oh, yeah.
You know what it does. You know what it's about. There's an eagle there. You know it's the United States of America. Come on.
Bipartisan, Democrats and Republicans both
Bipartisan.
love freedom. We
Democrats
love freedom. We love
freedom
eagles.
this year. It's amazing.
It's orange, not red, not blue. See, it's
Beautiful.
perfect.
Beautiful.
Yeah, and TEFCA
Yeah.
does kind of sound like a Borg thing, like, you know, I don't know.
Yeah.
No one likes that. So we also, just for context, we also had our designer, Maxim Kowalczyk, just FYI, she may or may not be my youngest sibling. So we just like rebranded this little for you so you could see how it really works, because we also, you know, we like a lot of the changes that that ONC, ASTP, whatever, however order we're doing that, made about like how you can, like, you know, you can kind of file complaints directly with the agency. And so like the eagle is y'all, and you're like coming down on this. What do you think? Like, what do you think? You think it works? I think it works.
Well, I was going to say keep your day job, but your day job is marketing.
It's not our day jobs. Like,
We're
it's
retired.
already not our day jobs.
Yeah, we're retired. We're formerly known as the best PR girls
We'll
in
take
America.
it under advisement. It's going to have to go through many committees. We'll have to get a FACA meeting on it. You know,
We'll send it through. We'll send it through.
Micky,
We'll have Aneesh write an email.
No, I think the response would have been friendly amendment. I'm so honored and inspired by your creativity, and I welcome all listeners of this wonderful show to put your minds to work on what it means to you to see the benefits of health data sharing for the country.
That's right.
That's
Look
what I'm
at the
talking about.
politician.
And so submit your rebrands. Submit your homegrown rebrands of TEFCA. We'll see who wins.
Everyone.
Okay.
Everyone.
Last words.
Yeah. If our loyal listeners, all five of the people watching the show, submit your own rebrands, and we will also grade them and share them. We will send them in an email.
You might make t-shirts. We might make t-shirts. I don't know. Yeah. So we'll see.
Like,
also,
we'll end up being Tuggy McTugtug, or what was the thing that happened in the UK?
Bodie McBoatface, but nice. Very close.
I love that. Bodie McBoatface.
All those things. They can happen. Also, only about 1/10 of our comments are coming through. So you have many fans. You may have to go to the actual post and see everything that Brendan Keeler said about you both. I don't know.
Okay.
They did not.
Great.
So final words, Micky, what would you like to say to our 12 loyal fans, or 10?
It's been an honor to be here, and it's been really fun.
That's right.
And call me anytime.
Micky.Tripathi@hhs.gov. Aneesh, what do you have? Well, you kind of already said it, but would you like to retell our massive fan base?
Thanks, Micky, for his service, and welcome everybody to be a part of this. It takes us to work on the things that they're setting up. So it takes two to tango. We have to show up. So it's our time.
Awesome. Well, thank you both. God bless America.
Everybody.
We'll send this.
Later.
We'll send this to your team. We'll talk to you guys later.